Let's begin with the case of Ms. Bayless, a delivery driver who was in a severe car accident, resulting in a badly injured left knee. In the emergency department, an exam was performed under anesthesia and with the knee bent at a 90-degree angle. In this position, the physician was able to pull the woman's tibia anteriorly on her femur. This motion is known as an anterior drawer sign because the tibia can be pulled forward from under the femur like opening a drawer. That hurts just thinking about it. What specific knee injury did this woman sustain? In our last lesson, we learned about the femur, patella, and most muscles that move the knee. But to understand this complex and frequently injured joint, we need some more detailed anatomy. The knee joint is really interesting. It has all the bells and whistles of a typical synovial joint and then some. The knee is a hinge joint between the medial and lateral condyles of the femur and the medial and lateral condyles of the tibia. Remember that the fibula doesn't directly articulate with the femur, though the patella does. With that said, the patella and fibula are still both crucial elements of the knee joint, as we will see. Since it's a hinge joint, can you guess what kind of ligaments are found on either side of the knee? Yes, collateral ligaments. The tibial collateral ligament, referred to by most as the medial collateral ligament, or MCL, is a relatively wide and flat ligament that connects the medial epicondyle of the femur to the medial condyle and proximal shaft of the tibia. It's considered an intrinsic ligament because it blends with the capsule of the knee joint. Remember, the capsule is a connective tissue sleeve that covers many synovial joints. The fibular collateral ligament, commonly known as the lateral collateral ligament, or LCL, connects the lateral epicondyle of the femur to the head of the fibula. It's much more cord-like and more mobile than the medial collateral ligament. And it's an extrinsic ligament, given that it is not connected to the joint capsule. The so-called tibial plateau is not exactly flat, since between the medial and lateral condyles of the tibia is a projection known as the intercondylar eminence. On either side of this intercondylar eminence sit the menisci of the knee. These are fibrocartilaginous pads that form articular discs, but you really only hear them called menisci at the knee. The medial meniscus is more C-shaped when seen from above, while the lateral meniscus is more O-shaped. The menisci sit atop the articular cartilage of the tibia and are connected to the tibia at their edges by small attachments known as coronary ligaments. Each meniscus functions to slightly deepen its articular surface on the tibia. The menisci act almost like cup holders for the rounded condyles of the femur, helping them to sit on the much flatter tibial condyles. The menisci also cushion the femur on the tibia, so they're protective as we walk, run, and jump. It's important to note that the most medial edge of the medial meniscus is solidly connected to the medial collateral ligament, making the MCL less mobile than the lateral collateral ligament. This relationship also means that when the MCL tears, as from sudden change in movement or an impact that puts excessive stress on the ligament, the medial meniscus is often damaged as well. Since the LCL doesn't attach to the lateral meniscus is not torn as often. Remember that cartilage is avascular, so meniscus tears may heal slowly, poorly, or not at all. Not only can that depend on how severe the damage is, but sometimes the degree of healing relates to which part of the meniscus is damaged, as some parts are more vascularized than others. In my gross anatomy experience, I frequently see elderly cadavers with menisci that are dried out and worn down to just brown slivers of fibrocartilage. Sometimes the articular cartilage beneath the menisci is also eroded, in some cases to the point where bone was rubbing against bone in the knees. causing pitting or even polishing of the facing surfaces of the femur, tibia, patella, or all three. Between the medial and lateral condyles of the tibia, the cruciate ligaments attach to the tibia's intercondylar eminence, which really consists of two small peaks, one for attachment of the anterior cruciate ligament, or ACL, and the other for the posterior cruciate ligament, known as the PCL. Now, cruciate means cross-like, since these two ligaments form an anterior to posterior X within the knee joint. The modifiers anterior and posterior are really best understood relative to the attachments on the tibia. In other words, the anterior cruciate ligament attaches to the anterior part of the intercondylar eminence on the tibia, and then passes posteriorly to attach to the posterior medial part of the lateral femoral condyle. The ACL prevents the femur from moving posteriorly on the tibia. The PCL, on the other hand, attaches on the posterior part of the tibia's intercondylar eminence and then passes anteriorly to attach to the anterolateral side of the femur's medial condyle. The posterior cruciate ligament prevents the femur from moving anteriorly on the tibia. Since they are within the capsule of the knee joint, the cruciate ligaments are said to be intracapsular. But interestingly, they're also said to be extrasynovial, meaning the cruciate ligaments are outside the thin, transparent synovial membrane that lines the joint. Though synovial membranes line all freely movable diarthrotic joints, in this case, the knee's synovial membrane folds around the cruciate ligaments, technically excluding them from being within the membrane while still within the joint capsule. There are a couple of other smaller knee joint ligaments called the arcuate and oblique popliteal ligaments. Both of those help strengthen the posterior part of the joint. However, the anterior stability for the knee joint is largely derived from the tendon of the quadriceps femoris muscles and the patellar ligament that quadriceps tendon becomes. In fact, the sleeve-like capsule of the knee joint is deficient anteriorly and is essentially replaced by the tendon of the quads and patellar ligament. Additional lateral stabilization is provided by the iliotibial tract and the vastus lateralis muscle, while vastus medialis helps with medial stability. So as some of you probably know, strong quads help prevent knee injuries. The knee also has numerous bursae, and though we haven't covered the bursae of many other joints, remember that bursae are friction-reducing pockets of synovial membrane between adjacent structures at a joint. At the knee, there's a suprapatellar bursa anterior to the distal femur and deep to both the quadriceps tendon and posterior patella. This bursa facilitates movement of those structures against the femur when we flex and extend our knee. The subcutaneous prepatellar bursa sits between the skin and the lower half of the patella and the proximal part of the patellar ligament. By contrast, the subcutaneous infrapatellar, or sometimes called superficial infrapatellar bursa, is more distal and sits between the lower part of the patellar ligament and the tibial tuberosity. Specific actions or positions can relate to a particular pathology. Bursitis of the prepatellar bursa is known as housemaid's knee, while the name clergyman's knee is given to the infrapatellar bursitis. Consider that someone who scrubs floors on their hands and knees puts pressure on the prepatellar bursa, while a kneeling person puts pressure on the infrapatellar bursa. Now, you might say nobody still scrubs floors like that, which I doubt is true, but also consider that occupations like carpet laying or flooring installation would necessitate that same hands and knees position. In addition, the swelling, redness, pain, and even heat sometimes associated with bursitis of the knee can also be caused by acute trauma, an infection, gout, or other rheumatological conditions. Before studying the muscles of the leg region, let's look at the rest of the tibia and fibula. We've talked about much of the proximal tibia, its condyles, intercondylar eminence, and tibial tuberosity where the patellar ligament attaches. On the proximal tibia's posterior aspect is a landmark called the soleal line. Continuing distally along the shaft of the bone, the tibia is more triangular than round in cross-section, and it has a raised ridge along its anterior border. You can feel that easily on yourself. It's so close to the surface that we've all probably skinned our shin a time or two. At its distal end, the tibia expands medially into a prominence called the medial malleolus. And on the lateral aspect of the distal tibia, there's a fibular notch to receive the adjacent fibula. The result of the juxtaposition of the tibia and fibula creates both a proximal tibiofibular joint just posterolateral to the knee, as well as a distal tibiofibular joint at the ankle. As for the fibula, we already met the fibular head located proximally, which is followed by a constricted neck. The thin shaft of the fibula travels distally to terminate in a prominence known as the lateral malleolus. Between the tibia and fibula runs the interosseous membrane that not only helps connect the two leg bones, but also aids in compartmentalizing the leg. The leg can be referred to as the crural or sural region, and like the fascia lata of the thigh, the leg muscles are surrounded by a dense covering of fascia called the crural fascia. Two deep extensions called the anterior crural intermuscular septum and posterior crural intermuscular septum connect this outer sleeve of fascia down to the fibula. So, along with the interosseous membrane, these help divide the leg into its three subdivisions, an anterior, lateral, and posterior compartment. A third major plane of connective tissue, the transverse crural intermuscular septum, further separates the posterior compartment into a group of superficial muscles and a group of deep muscles. To generalize compartment functions, the muscles in the anterior leg all cross the anterior ankle to cause dorsiflexion of the ankle, like walking on your heels. In addition, some also cause extension of the toes, like pointing them toward the ceiling. Likewise, muscles in the posterior compartment can plantar flex the ankle, like walking on your toes. And some also flex the toes, like curling them toward the sole of your foot. Several posterior compartment muscles also cross the posterior knee, so assist in flexing the knee. Muscles in the lateral compartment of the leg evert the foot, while some tendons of muscles in both the anterior and posterior compartments cross the medial ankle to invert the foot. In order to understand the insertions of the leg muscles and their actions on the foot and toes, we should quickly review the bones of the foot. There are 7 bones of the ankle region, collectively referred to as the tarsals. The talus is the tarsal that articulates at the ankle with the inferior articular surface of the tibia, as well as both the medial malleolus of the tibia and the lateral malleolus of the fibula. The talus sits proximal to, or you might say atop, the calcaneus, which is the tarsal that forms our heel. Medially in the foot, the navicular bone articulates with the anterior part of the talus, and distally, the navicular articulates with 3 small wedge-shaped bones called the cuneiforms. Now, these can be called the first, second, and third cuneiform, or alternatively, the medial, intermediate, and lateral cuneiform. But the lateral cuneiform isn't the most lateral of the tarsals. The cuboid bone sits laterally and articulates with the anterior part of the calcaneus. Now, I caution students not to confuse the talus with the general term tarsal, which is the full group that includes not only the talus, but the calcaneus, navicular, cuboid, and 3 cuneiforms. Distal to that final row of 4 tarsals are the 5 metatarsals of the sole of the foot. So the relationship is not a 1-to-1 ratio. Each metatarsal has a proximal base, a shaft, and a distal head, as we saw with the metacarpals of the palm. The first metatarsal is the most medially located, belonging to the big toe. And like in the hand, metatarsals are designated with Roman numerals 1 through 5, with 1 given to hallux, which is the name for the big toe or great toe, and Roman numeral 5 for the metatarsal of the little toe. But remember, due to the limb rotation during development, the big toe is medial while the thumb is lateral. As in the thumb, the big toe has 2 phalanges, a proximal and distal, and the other 4 toes have 3 phalanges, proximal, middle, and distal. Each phalanx is said to have a base, shaft, and head, though in the smaller toes, the middle phalanx is nothing more than a small rectangular bone. Due to the similar naming, whether in the morgue, the classroom, or in clinical practice, foot versus hand has to be specified for phalanges. Now let's get more specific about the movements caused by the various muscles in the leg. Dorsiflexion and plantar flexion occur at the true ankle joint between the talus and the tibia and fibula. But inversion and eversion occur within the foot itself. When you look at the articulations among the tarsals, you can see the relatively straight medial to lateral planes at which gliding movements of inversion and eversion occur. It's a common misconception or a misstatement that inversion and eversion occur at the ankle. In fact, they occur within the foot itself. Each muscle compartment of the leg has a unique nerve supply, which is most convenient for learning them. Do you remember that the sciatic nerve is composed of a tibial portion and common fibular portion? These 2 nerves typically diverge from one another in the popliteal region behind the knee, terminating the sciatic nerve. And from there, the tibial nerve travels distally and stays in the posterior compartment to supply all leg muscles posterior to the interosseous membrane. The common fibular branch of the sciatic heads laterally in the popliteal area for a short distance, and near the head of the fibula divides into a superficial fibular nerve that supplies the 2 muscles of the lateral leg, and a deep fibular nerve that, as I tell my students, passes deeply forward to supply the muscles in the anterior leg. And this is the reason that the sciatic nerve off the sacral plexus, by virtue of its branches, supplies all muscles below the knee. Now, more about the compartments of the leg. Did you know that the leg is one of the more common limb regions where compartment syndrome occurs? Overexertion or training too fast can cause painful swelling from inflamed muscles. This compresses vessels and nerves because the crural fascia is too inflexible to quickly adapt and accommodate the swelling. In addition to pain, numbness and a faint pulse in the area are signs of the increased intracompartment pressure. This pressure can damage nerves and muscles by cutting off their blood supply, but usually can be controlled by simply recognizing the injury and modifying the activity by resting the leg. But sometimes an injury can cause an acute compartment syndrome due to swelling from an internal bleed, as can happen with a broken bone. In cases with acute onset, the crural fascia has to be cut to relieve the pressure, an emergency procedure called a fasciotomy. At the ankle, the crural fascia thickens anteriorly into transverse bands known as the superior and inferior extensor retinacula. These keep tendons of the anterior leg aligned with the ankle and prevent the bowstringing that would otherwise happen during dorsiflexion. It's as if we're wearing a binding or band around the ankle, as we saw at the wrist. The superior extensor retinaculum is continuous with the flexor retinaculum that sits superficial to tendons of muscles in the posterior leg. There are also thickened retinacula that bind down the lateral compartment's muscle tendons. These aren't the ligaments of the ankle joint. We'll study those in the next lesson. These retinacula help secure tendons to facilitate the actions of their muscles. Now, there are 4 muscles in the anterior leg: tibialis anterior, extensor hallucis longus, extensor digitorum longus, and a small muscle almost like a bonus tendon called fibularis tertius, also known as peroneus tertius. In anatomy, the word peroneus is gradually being replaced by fibularis. This is because peroneus is Latin for the Greek term for the fibula. So why mix the Greek for the fibula with the Latin word tibia? The other issue relates to chronic mispronunciation. Some people call these perineal muscles, and we know the perineum is the diamond-shaped region between the thighs, which is nowhere near the leg or the fibula, unless you're sitting cross-legged, I suppose. Okay, let's start with tibialis anterior. When you feel along your shin, the muscle mass immediately lateral to the sharp crest of the tibia is tibialis anterior. It takes origin from the proximal half of the tibia's lateral surface, as well as the interosseous membrane. The large tendon of tibialis anterior can be easily seen passing across the anterior and medial aspect of the ankle to insert on the medial cuneiform and the base of the first metatarsal. Now, because it crosses the anterior ankle, does tibialis anterior dorsiflex or plantar flex? If you said dorsiflex, you're correct. And because it crosses the medial aspect of the ankle to insert on the foot, does it invert or evert the foot? Yes, tibialis anterior causes inversion. The extensor hallucis longus muscle originates off the interosseous membrane, but also off the anterior fibula. As its name implies, extensor hallucis longus inserts on and extends the great toe. And as a longus muscle, it goes the long way and inserts on the distal phalanx. But its tendon crosses the anteromedial aspect of the ankle, so it also dorsiflexes and inverts the foot. The extensor digitorum longus muscle takes origin off the interosseous membrane too, but additionally off the lateral condyle of the tibia and the anterior fibula. It inserts on the middle and distal phalanges of the 4 lateral toes. Extensor digitorum longus's name reveals its function in toe extension, but because its tendon crosses the anterior ankle and then fans out laterally toward the smaller toes, extensor digitorum longus can also assist in ankle dorsiflexion and eversion of the foot. Now, in most people, there's an additional tendon that runs off the distal and lateral portion of extensor digitorum longus, but doesn't attach to a toe. When present, this tendon is called fibularis or peroneus tertius, though its muscle belly is indistinguishable from extensor digitorum longus. Fibularis tertius inserts on the tuberosity or tubercle at the base of the 5th metatarsal. Because this tendon crosses the anterior and lateral aspect of the ankle, it dorsiflexes and everts the foot. Now, tertius means third, and we're about to meet its 2 other fibularis buddies in the lateral leg. But before leaving this compartment, let me remind you that all 4 muscles of the anterior leg are supplied by the deep fibular nerve off the common fibular branch of the sciatic nerve. The 2 muscles in the slender lateral leg compartment are fibularis longus and fibularis brevis, also known as peroneus longus and brevis. The fibularis longus originates on the proximal lateral aspect of the fibula and has a much longer tendon, as its name implies. That tendon sits superficial to the belly of fibularis brevis, which originates more distally on the lateral fibula. Both muscles send their tendons across the lateral ankle and function to evert the foot. But fibularis brevis inserts on the tuberosity of the fifth metatarsal with its tertius companion, while the fibularis longus really goes the long way. It passes completely under the sole of the foot from lateral to medial and inserts on the inferior aspect of the base of the first metatarsal. That's the one on the big toe side. Not only does this facilitate eversion of the foot, the tendon of fibularis longus helps support the sole of the foot, as we'll see in our next lesson. Both muscles of the lateral compartment are supplied by the superficial fibular nerve, a branch off the common fibular, off the sciatic. The posterior compartment of the leg contains 6 or 7 muscles, depending on whether or not the person has a plantaris muscle. Yes, just like in the forearm, there's a variable muscle in the leg. But let's not start there. Let's start with the most obvious muscle of the posterior leg, which is the gastrocnemius. It makes up the prominence that most people call the calf. Gastrocnemius is a two-headed or two-bellied muscle that crosses both the knee and the ankle. Its lateral and medial heads originate off the respective posterior aspects of the femoral condyles and the popliteal surface of the femur. The heads combine to insert on the posterior aspect of the calcaneus by the calcaneal tendon, which most people call the Achilles tendon. Now there's an eponym that takes us to a mythical level. Because it crosses the posterior knee, the gastrocnemius assists in knee flexion, along with the hamstrings and other muscles in the thigh. And because it crosses the posterior ankle, gastrocnemius mainly acts in plantar flexion. Deep to the gastrocnemius is the soleus muscle. It takes origin off the soleal line of the tibia and the posterior fibula and inserts along with the gastrocnemius by the same calcaneal tendon. Because soleus is a wider and slightly more distal muscle, its belly can typically be seen on either side of gastrocnemius. A soleus doesn't cross the knee, but plantar flexes the ankle with the gastroc, as gastrocnemius is often called. Within the calcaneal tendon, you really can't differentiate gastrocnemius and soleus. The tendons literally fuse. Though both muscles aid in running and jumping, the soleus is more of an endurance muscle and also aids balance when on one foot. Soleus is really the prime mover in plantar flexion when the knee is bent, since gastrocnemius is slack in that position. And here's a fun bit of anatomical history related to our rule of adjectives. We know that the triceps brachii is in the posterior arm, but is there another triceps? Well, the two heads of gastrocnemius and the soleus were sometimes referred to as triceps surae, meaning a three-headed muscle of the leg, though that has fallen out of style. Who knew there was style in anatomy? The last muscle that might be in the superficial region of the posterior leg is the plantaris. It is a variable muscle that has a tiny, dare I say, cute little belly that takes origin from the femur's lateral supracondylar ridge. It has such a long tendon that it gets the nickname the freshman nerve. That's because gross anatomy is typically taken during first year of medical school, and newbies often mistake the plantaris tendon for a nerve. The tendon of plantaris sometimes fuses with the calcaneal tendon, but other times stays separate to attach to the calcaneus. Most people have a plantaris, an estimated 80% or more depending on population. And when it's present, it is said to weakly flex the knee and weakly plantar flex the ankle. But as with palmaris longus of the forearm, the plantaris tendon can be important clinically in an autologous graft, where it can be sacrificed for a tendon replacement or repair. Now, these 2 or 3 muscles in the superficial posterior leg are separated from the 4 deeper muscles in the posterior leg by the transverse intermuscular septum. The deep posterior leg includes tibialis posterior, flexor hallucis longus, and flexor digitorum longus, with adjectives that mirror 3 of the 4 muscles of the anterior leg. Remember tibialis anterior and extensors hallucis and digitorum longus? The 4th muscle of the deep posterior leg is popliteus. Now, popliteus crosses only the knee, originating off the lateral femoral condyle and inserting on the proximal posterior tibia. It is said to unlock the knee by slight rotation at the knee joint. The 3 deep posterior muscles that mirror their anterior counterparts have an unusual relationship in the posterior leg. The belly of tibialis posterior is intermediate, while flexor hallucis longus is lateral on the little toe side, and flexor digitorum longus is medial on the big toe side. When you think of their functions, that is odd, but the tendons of flexor hallucis longus and flexor digitorum longus make an X at the medial ankle and then approach their respective insertions. Tibialis posterior originates on the posterior tibia, posterior fibula, and interosseous membrane, and it passes posteromedially and inserts on most of the tarsals and metatarsals, as we'll see in our next lesson. Tibialis posterior functions to plantar flex and invert the foot. Flexor hallucis longus takes origin from the posterior fibula and interosseous membrane and inserts on the plantar surface of the distal phalanx of the big toe. Flexor digitorum longus originates on the posterior tibia and inserts on the distal phalanges of the other 4 toes. Besides flexing their respective toes, since both flexor hallucis longus and flexor digitorum longus cross the posteromedial ankle, they assist plantar flexion and inversion of the foot. They're also important to the arches of the foot and for attachments of some muscles in the sole of the foot. Remember that all muscles of the posterior leg, whether superficial or deep, are supplied by the tibial branch of the sciatic nerve. Before we close, let's return to our clinical vignette. Remember Miss Bayless, who was injured in a crash and wound up with an unstable knee joint? What specific damage would allow the tibia to be pulled anteriorly from below the femur? If you remember, the cruciate ligaments work together to prevent anterior and posterior displacement of the femur and tibia at the knee. In this case, her anterior cruciate was torn, allowing her tibia, to which the ACL is anchored anteriorly, to be pulled forward beneath the femur. Physical therapy can be prescribed to strengthen the quadriceps femoris and supporting hip musculature. But if that doesn't stabilize her knee, surgical repair of her ACL may be necessary. In our next lesson, we'll continue our study of the lower limb with a little fancy footwork, and we'll talk about the many interesting features of our amazing and hardworking feet.